my talk is on diagnosis and management of non-unions in lumbar spine. So how we usually diagnose a non-union or any other disease? We see symptoms, signs, advise some investigation, look at the radiology and diagnose. What we do when a patient after a surgery comes to us. So this is our usually diagnosis after a good looking X-ray for initial months. If patient complains of back pain, loading, whether we ask is it loading, persistent, even if it's worsening, are we looking closely at the instability signs, persistent leg pain or new symptoms after a couple of months, fever or wound discharge. So all of these can lead to non-union, which is relatively common in 10 to 15% of lumbar fusions. So when we see what we see on X-rays, so are the X-rays a better modality for diagnosis of fusions in lumbar spine? If we see these X-rays, the A view, you can see the pebble-like appearance on AP view, which is becoming more homogeneous after 3 to 6 months, and after a year you can see it has been nicely incorporated in C view. But AP view is the better view for posterior lumbar interbody fusion. When we attempt to look at the P leaf or T leaf or interbody fusions, we should be looking at a lateral view, or an oblique view when we attempt to look at both the posterolateral as well as the anterior fusion. So each view has a different application. Dynamic views, how many of us really take dynamic view in a post-operative patient? I want you to raise hand and tell me, in a post-operative patient after 3 months, yeah, so what are the criteria you consider for each and every patient? Okay, what's your duration or what time you decide? Okay, okay. Great, great. So this should be the norm to look for any fusion in a post-operative patient, not looking for a static X-ray. We should always incorporate a dynamic X-ray in post-operative patient. I do for 3 months, but Dhiraj does at 6 weeks and later on. But at 3 months, it's highly recommended to look for fusion. We should go for a dynamic views. For lateral bending, if you want to look for anteroposterior fusion, but for flexion extension and looking at the Cobb's angle and at the upper and lower end plate is highly advisable. Interspinous distance, if there is a change of the interspinous distance for more than a millimeter, it is suggestive of a non-union. Okay, so always make an attempt to look at the interspinous distance when the spinous process is intact. Yes, we all feel that CT is the best modality tool after the dynamic X-ray. Even if the best available CT, a multi-slice, 1.5 closely cut, 200 plus cut slice, whatever available, a multi-axial cuts, still it is not a perfect modality of choice for look for a non-union or look for a fusion. The best thing is incorporation of both the modalities. Okay, we should look for the dynamic X-rays as well as a CT scan on follow-up at 6 months. So both of these has more than 95% of sensitivity. Yeah, so look for the other signs of the implants. So the subsidence of the cage, the change in position of the cage in follow-up X-rays, lucency around the cage and later on sclerosis is definitely a telltale sign. Lucency along with sclerosis around the cage is definitely a telltale sign of a non-union. Pedicle screws, when it is broken, when there is a lucency around the screws, and when it, along with sclerosis is definitely a signs of non-union or loosening of implant. If there is a plowing or backing out of screw, it should be suggestive of non-union. So in some cases, even with we as an orthopedic surgeon believe that there is always a race between the implant and the healing process. So in some cases, even when implant gave away, the nature has healed this fracture. And even when surgeon has attempted his best by scraping off the tissue, putting all the screws out of the pedicles, still the nature has sometimes healed the fracture. Yeah, so let's see the case 4. So case 4 is a TB spine with a paradiscal lesion. For this, only posterior fixation and fusion was done. But there is a big void, and a surgeon may have done a decent job. We believe that sometimes TB heals anteriorly and it may not always, and in this case the rod has broken. Apart from aseptic, we always have to look for an infection as a etiology. There can be a subtle infection which might be eating your graft and giving rise to the non-union. So just a little bit information on the bone graft. So the ideal bone graft, what we use is the iliac crushed bone graft, and it has all these 6 features of ideal bone graft. It is biocompatible with no immune reaction. It is bio-remodelable, osteoconductive, osteoinductive, easy to acquire, and as well as cost effective. Only some surgical side morbidity is only the problem. Okay. So these are the commonly used grafts. So locally available lamina. The problem with this is next to the iliac crushed bone graft. It is high in cortical bone, less trabecular bone, and less osteogenic cells. So we can improve the fusion part when we incorporate this with bone marrow aspirate. Second thing is allogenic bone graft. So most of us are using a dried or a morselized bone graft, allograft from Tata Hospital. So I suggest you use a fresh frozen femur head, which has a better next to, we can make it much better when we incorporate with this iliac crushed bone graft. So it is next to iliac crushed bone graft when we use fresh frozen femur head along with allogenic. So demineralized bone graft, yes, it's available to most of the companies. It has some BMPs, also has osteoinductive and conductive properties. The most important factor in managing non-union is treating the underlying pathology and trying to correct that. So smoking, diabetes, infection, mechanical instability, avoiding medications like NSAIDs and steroids, delaying radiation when we attempt for fusion, persist, treating the gap defect, especially the anterior gap defect whenever possible. So these are a few of the treatable conditions, but few things are not treatable. Thank you.